Good morning, everyone. We're so glad you're joining us. We're going to wait just another 30 seconds or so as we see our numbers are really beginning to climb for attendance. We're so glad you joined us. We will begin in about a moment. If you're just now joining us, we're waiting just another few seconds to let our numbers continue to climb, and we're so pleased you're taking your time with us this morning. We'll begin in just a moment. Well, good morning. We're so glad that you're with us this morning. We're so excited to have this fantastic program to present to you, and we're thrilled that you valued it enough to take your valuable time to spend with us this morning. So thank you so much. While we're waiting for additional folks to join, I would love to ask you to fill out our first poll question of the morning. You'll see it popping up on your screen there. And if you could just let us know which state you represent. Please just select what state you are attending from. We would be so grateful to have that information for us. We will have several polls this morning, so you'll see them pop up and we'll let you know when they're coming. So you'll have the option to make your selection and then to hit submit, and then we'll see where we land. So if you could make your final selections, we would love to know what state you represent, and then please hit submit, and we'll go on. So let's get started this morning. My name is Deb Dillingham, and I'm the Senior Director for Cancer Support Strategic Partnerships for Ohio and West Virginia with the American Cancer Society. It's my pleasure to welcome you to today's event. We ask that if you've called in from your phone that you please enter your name and your organization in the Q&A so we'll have record of your attendance. All lines will be muted during the entire program, and we ask that all questions be entered into the Q&A. We want to make sure that we have time to address those either during our panel presentation or after the event. If we don't have time to answer your question during, we will work with the presenters to answer your question post-event. I now have the pleasure of introducing to you our welcome speaker, Jim Pantales. Jim is a 17-year survivor of stage 3B/4 non-small cell lung cancer. He's an active advocate and activist, including participating in research IRBs at the University of Michigan, Veterans Administration, and Mercy Health Systems. He is a CIRB member with the National Cancer Institute, a peer reviewer on the CDMRP Lung Cancer Research Program, PCORI and MISHAR, and a member of the National Lung Cancer Roundtable. Jim is a father of 3 daughters. Stella is 16, Grace is 14, and Lita is 13. He lives in Michigan and is an avid motorcycle rider. Jim, welcome. We're so glad you're with us today.
Thank you, Deb. As Deb said, I'm a 17-year survivor, so I'm happy to be here. As a 17-year late-stage lung cancer survivor, I'm also the son of parents who both died of cancer. My mother from pancreatic cancer and my father from lung cancer. I'm a dad, a veteran, and a patient advocate, which in my instance means that I volunteer a lot. I sit on multiple institutional review boards that oversee cancer research at NCI, U of M, and VA. I work with NCI, PCORI, and Department of Defense and others, where I participate in the review of research grants. And I regularly go to Washington to plead with members of Congress for more funding for cancer research. The research that I work on and that I'm most interested in revolves around lung cancer stigma and nihilism. While lung cancer research has expanded greatly in the past decade, almost all of the funding has gone to the hard science side of the equation, and it's paying off. In the past 5 years alone, we've seen 35 new treatments approved by the FDA, and the outcomes for many patients are improving markedly. But on that front, we've still got a long way to go. My work on the softer side of the science remains hugely underfunded. The work I'm involved in is in changing the dialogue about lung cancer, creating tools and training to create and enhance empathic communications between clinicians and patients. Much of the work I'm doing now revolves around my work with the ACS-sponsored National Lung Cancer Roundtable and is tied to the aspect of lung cancer that are harder to treat because they're not molecular in nature. Lung cancer has the dubious distinction of leading all cancers in overall deaths. In fact, more Americans every year die from lung cancer than the next 3 cancers combined. It also leads all cancers in suicides, and results from a UC Davis study shows that 26% of patients diagnosed at a stage 3B or 4 elect either no first-line therapy or drop out of therapy after only 1 or 2 cycles. Much of that is tied to the stigma associated with the disease, and my work is directly aimed at changing or eliminating that stigma. So that's who I am. And a brief explanation of what I do. What I haven't addressed is why a guy from Michigan would be speaking at an event sponsored by the Ohio State University and dealing with Ohio and West Virginia. But that's pretty simple too. First, it's not game week, so I can get away with it and not have to talk any trash. The second is that my mother was born and raised in Martins Ferry, Ohio. So growing up, I spent most of my summers with relatives up and down the Ohio Valley. And I still have a lot of family in towns on both sides of the river. It's of great significance to me that when you look at maps from the CDC that show incidence per capita of lung cancer, the towns that I spent my summers in were all depicted in red. Steubenville, Youngstown, Weirton, Wheeling, all are adversely tied to disproportionately high levels of lung cancer. And I suspect many other cancers as well. So that's me. Now, before we begin our program, we want to recognize and thank our sponsors. Without the generous support of the Ohio State University and Harry C. Moores, this program would not be possible. Also, thank you to the Ohio Partners for Cancer Control and Mountains of Hope Cancer Coalitions for their continued support. And I'd like to thank all of you for attending. With that, I'll turn it back over to Deb to get the real work started here. Deb?
Tremendous, Jim. Thank you so much. We appreciate your comments. We appreciate your story, and we appreciate all that you bring. We appreciate it, Jim. Thanks. Let's take a look at the agenda for today. We'll begin our agenda with health equity and lung cancer screening with Dr. Scout. Next, we'll have a panel discussion around innovation in lung cancer screening. This will be followed by Emily Reising and Andrea Radford, both speaking about lung cancer and tobacco issues from their perspectives. So we have a full agenda for you today, and I think you'll find that this couple of hours will go relatively quickly. However, we do have the AAFP has reviewed the Health Equity in Cancer Virtual Series Lung Cancer webinar and deemed it acceptable for up to 2.0 enduring medical materials. Self-study AAFP prescribed credits. You will receive a certificate to claim your CEs within 2 weeks following the completion of the post-event survey. Our objectives for today's event can be seen on the current slide. Please note that the planning committee members and speakers have declared that there are no relative financial arrangements or affiliations with the organization that may affect balance, independency, objectivity, or scientific rigor for the CE event. Also, please note that slides will be available after the presentation, and this event is being recorded. Now it's time for our second poll. You'll see that pop up on your screen. What we'd like to know is, what is your role or sector as it relates to lung cancer? Please make multiple selections if it applies to you, or one selection if that applies. So once you've made your selection or selections, please hit submit, and we will gather that information before we move on. So I'll give you just a moment to make your selection or selections, please. Okay, while you're finishing up those selections, I'm going to move on and introduce our first speaker to you. We are so pleased to have with us this morning Dr. Scout. Dr. Scout is the Executive Director of the National LGBT Cancer Network and the Principal Investigator of the CDC-funded LGBTQ Tobacco-Related Cancer Disparity Network. In this capacity, he spends much of his time providing technical assistance for governmental tobacco and cancer-focusing agencies, expanding their reach and engagement with LGBTQ populations. He leads a team of specialists who focus on building tools and sharing strategies across state departments of health. We're so pleased you're with us this morning. Welcome, Dr. Scout.
Thank you very much. I really appreciate it. Ohio and West Virginia are some of my kind of favored states, and everybody else in the Midwest too, as a matter of fact, especially since I did a lot of growing up in Illinois. I realized that we get a lot of attention to some of the coastal states, and yet we do so much of the work in most of these other states. So I'm very happy to be here. And so as you'd heard, my specialty is really kind of focusing on what's happening related to the queer populations, the LGBTQI populations, related to both tobacco and cancer. So obviously this concept related to lung cancer screening is right at the nexus of those 2 points. And what I want to do as I start talking a little bit through some of what I'm going to say today is I want us to consider and think about how this isn't necessarily information specific to one set of communities, because among other things, our communities are incredibly diverse. You may or may not know that the general population, about 24% of the general population identifies as a racial ethnic minority. In my communities, it's 42%. So it's much more intersectional for us. And so I want us to think about taking this idea of learning a little bit more about LGBTQI disparities and issues related to access to care, lung cancer, tobacco use, and think of that as a lens from which we can take lessons that might apply across a lot of different populations. So with that, I'm also going to do this slightly differently. I guess maybe it's in keeping with the larger sense here, but I often do have slide decks and I romp through a whole bunch of kind of existing talking points. But I'm going to do something different right here because I'm going to instead think about talking to you about a few stories and see if that is something that ends up maybe approaching this from a different angle. So with that, I hope it does work, but I'm optimistic. So what I want to do is talk to you about a few different people in my life and the kind of experiences that they have, including myself, that end up contributing to our ability to resist tobacco use when we're young, what our interaction is with the healthcare system, what our interaction is as far as just actually even valuing our own level of health. So let's start with one of my favorite people to talk about, actually, is the mother of my kids, one of my ex-partner, Alice. And Alice is right now about my age, so she's in her 50s, and she has been smoking her whole life. And as I just confirmed this morning, she's never gotten a lung cancer screening, despite actually currently having a primary care provider who obviously should be encouraging her to get this lung cancer screening. But let's talk about kind of what happens pretty early on in this trajectory. Imagine now, if you will, if you've never considered what it might be like for an LGBTQI person in their teen years, our average age of coming out is about 12 or 13. That means that at the exact same time, we're dealing with all these issues related to puberty. You know, I think we've all seen middle school. It's a messy, messy place. It's also not a place where people are actually very kind, right? In the middle of that maelstrom of emotions, of bodily changes, everything like that, most of us are also at that time realizing that there's something extra different about us. Whether it's that, you know, like Alice, she wasn't attracted to the guys, she was attracted to the women. Or like myself, the idea of the oncoming puberty didn't seem to make sense. Obviously, as a transgender guy, that meant that puberty for me ended up being a much more traumatic experience because it was solidifying and changes in my body that would take surgeries to undo and would stop the world from seeing me as who I was. So in the middle of that maelstrom of emotions, Alice, myself, all of these other young LGBTQ folks are realizing that we don't fit. And one of the things that is unfortunate and different about our communities is since we kind of randomly emerge in different families, it means that we're not usually born into a family that can teach us how to navigate the social exclusion of being LGBTQI. So unlike a lot of racial and ethnic minority families, you may at least be embedded in a group of adults who've already figured out how to survive in a hostile world. With the LGBTQI population, that can be very different. And it really has some profound impacts across our lifespan. Like as I was just thinking about this, I'm not sure if non-LGBTQI people understand what would be routine in my communities around Thanksgiving. And that's that I would never presume that people are going to go home to their families on Thanksgiving. I always, before I would even ask about what they're doing for Thanksgiving, ask if their family accepts them and whether the idea of going home to their families is even an option that might be on the table for them. I certainly would never presume to think that could be an option because for so many people, there's been such aggression and such hostility by their families. So there's these substantive kind of changes. And when that happens, when you're 12 or 13 years old, if you do feel that level of family exclusion, it can really be devastating. It undermines your ability to develop a positive, healthy self-image. For a lot of people, it means that we resort to coping skills in order to deal with the pressure of this social exclusion. One of those negative coping skills, of course, is tobacco use. For too many of us, it also has to do with taking up other addictions, alcohol use, different things like that, because there's a lot of these conflicting emotions that we can't resolve. And fundamentally, we feel as if we're born into a world that for whatever reason does not seem to want us and does not seem to welcome or value us. And of course, as people in the tobacco world, I think we all understand that the average age of onset is 12 or 13 years old for tobacco use, right? So these two things are happening in such synchronicity that unfortunately it's practically a recipe for the idea that we're going to end up having a smoking disparity. And if you're not familiar with it, we do use combustible tobacco at rates that are about 40% higher than the general population. And in addition, our tobacco disparity as a set of communities had been getting smaller. So we had been getting closer to general population tobacco levels of use until we started to measure not just combustible, but all tobacco use. Once you add in e-cigarettes and different things like that, now our disparity is turning the other direction and it's starting to climb yet again. So imagine, you're one of these teens trying to navigate all of these ways. You suddenly feel like not only is, the world a maelstrom, are all your friends changing, are you changing, but some of those changes that you're understanding about yourself really leave you feeling like you're extra, not welcome. And for many of those youth, it means Gay, Lesbian, Straight Education Network just came out with their once every, I think it is 2 years, school climate survey. And in that, it unfortunately paints this really troubling picture of how many of our youth experience overt discrimination, often from school administrators in their schooling. So now you're not sure if you have welcome from your family, right? You go to school and you're not sure if you have welcome from the school. Actually, one of the things that can really stabilize that if there's a gay-straight alliance in the school, that's really super helpful. But especially for a lot of students in the less urban areas, those types of things don't exist either. So not only are you suddenly feeling as if your your mentor group from home may not be on your team, but your mentor group from school may also be actively hostile to you even. A lot of the students in the school climate survey talked about the number of times that they heard the teachers or administrators in their schools using slurs against them. So this burden of social exclusion starts to compound itself. And then as we work through the teens, we get into the 20s. Now, it might have been in the teens, people started to use tobacco because they were thinking that there was, they were trying to fit in with someone, right? They were trying to ameliorate the stress they felt from the social exclusion. Then as it solidifies into ongoing tobacco dependency, you end up, of course, kind of joining the group of people like yourself. And if you're in the LGBTQI communities, it means that you're often trying to reach out to other community members. And this is where we start to see the beginning of how tobacco use is also what I always consider a socially transmitted disease. It's one of those things where I remember one of my earlier memories when I was being feted at an event because I was about to leave town to go to a big civil rights thing and move out of town, was at my going away party. I looked around at one point and the rooms had been packed with people from head to toe. And I realized I was alone in my apartment. Why was I alone in my apartment at my own packed going away party? Because everybody had crammed onto the back porch to start smoking. And as we see the socially transmitted disease phenomena, you realize that, I used to ask people, we've had clean indoor air in a lot of places for many years, right? So you wouldn't think that the idea of smoking in bars is necessarily as much of a social contagion these days. But back when I was doing a Truth Initiative research project, we talked to people about how and where they started smoking for the queer community members. And what we find is that many of them would start smoking in non-smoking environments. For example, youth group members would start smoking at youth group meetings for sexual and gender minority youth. Obviously, they didn't allow this inside these meetings, but it was this phenomena of when a group of people went out and started smoking, you wanted to be part of the group. You didn't want to be alone. So you suddenly see this kind of contagion phenomena related to this. And then the thing I think that we want to keep in mind is how does this affect people? Again, like I said, Alice, who I'm talking about, is actually white, but like I said, the population is much more diverse than even the general US population. So now imagine, let's say you're Phoenix, one of my other buddies. Phoenix is an African-American, non-binary, academic, quite successful professor, but Phoenix has struggled for all of their life with the fact that they have a lot of acceptance from their family, as long as they don't bring up this idea of being queer very loudly. As long as you keep it something that's not really acknowledged, because between the religiosity in the family, the roots of the religiosity in, the ancestry, it's not overtly spoken out against, as long as you keep it quiet. But what kind of message does that tell any people like us? You're okay as long as you don't talk about who you really are. It gives us that consistent drumbeat of a message that who we really are is certainly not valued. It's something to be kind of barely tolerated. So then, you talk about how this continues to emerge throughout the lifespan. And actually, let me also bring up another one of my friends. So what about Joanne Keatley, an amazing leader in the LGBTQI communities? She has been historic as far as the number of things she's led across the country. She started University of California, San Francisco's Trans Center of Excellence. And it still to this day is some of the only places you can find guidelines for how you should be treated that you can often have to take and give to your doctor because your doctor has no clue how to treat trans people. Well, Joanne started her journey through this country, and she was a smoker for many years, but she started her journey through this country by coming over to the United States as an undocumented immigrant in the trunk of a car. So again, imagine this concept of you're starting from a position where you're already having to step so many steps up just to get on an even footing with the general populace in the United States. But now in addition to it, in her circumstance, she realized that being raised as a boy did not fit her by any means. And what we see too often is the case in those kind of circumstances is that people will go to incredible levels of self-harming behavior as they come to this reconciliation of who they really are. And they find a place where they then can be welcomed for who they are. One of my other friends is again, an amazing trans leader, in this case, a white trans woman. And she talks about how she had professional support. She had a family, she had kids, she had financial stability, she had a huge number of friends. And she kept doing more and more addictive and self-harming behaviors like cutting because she couldn't face the fact that the he she was pretending to be did not fit. Until one day she finally decided she had to announce it to the world because she was putting her life in danger by not doing this. So she announced it to all those groups of people. And within 1 year, she lost every single one of those things that I had mentioned. They were all gone. She hasn't seen her kids since. Everything was gone. And she was sitting in a bar stool, realizing that for all the guys who'd come up and propositioned her for sex for money, that was actually one of her only options. Actually, I shouldn't say one. It was just her only option for getting any kind of income at that point. So we see how this layer and stacking of the social exclusion continues to like weigh on the people as they go throughout their lifespan. And then, you know, one of the things, not only is it kind of socially contagious, but let's sneak back to Alice for a second. One of the things that I see going on with her throughout her lifespan, you know, and Alice is actually, she's one of those people, and she'll be very open about this, talking about the other addictions she used to deal with this social exclusion. So she was using drugs, she was using alcohol. She is super proud of getting sober, especially around the time when our kids were born. And that's obviously a gargantuan life accomplishment, something where you really have to consider all of the different ways that these things have deep roots in your life. You got to face them and you got to dig out those roots. But of course, what did she also find, as we're probably familiar with in so many of those 12-step rooms, at the same time she was spending a lot of time there, that people were smoking like chimneys, like absolute chimneys, right? So she suddenly was in a group of people where at the same time they're celebrating like a deep life step of how they were changing and resisting all of these negative health influences, they were participating in what we know is something that was also incredibly likely to take years off of their lives. So there's all these kind of different ways throughout the lifespan that this mutates and continues to build as well. Another one of my friends, Sophia. So this is a Latinx trans woman who is in Puerto Rico, and for many years worked to try and organize the other Latinx trans women in Puerto Rico and try and resist the level of systemic discrimination they would experience from the police there. And let me also say, this is really common, particularly in areas that are less urban. Even when I was growing up, when I was in Chicago, which is urban, whenever Gay Town, or Boys Town as it's called in Chicago, is right around Cubs Field, Wrigley Field. And unfortunately, when baseball goers would get drunk, they would have a tendency to try and find anybody that they thought was too effeminate or too butch or something like that and attack them, no less. But the problem with that was that even when we go to the police, it didn't mean that the police were our safe haven. More often, they continued to abuse us. So this concept that like trying to organize our own communities because the police are not our friends, obviously with George Floyd, everybody in the world understands how the police are not necessarily even-handed with some members of the population. And the way this can be extreme in our communities is it can be very tragic. I'm actually pausing a little bit because I kind of don't want to say some of the things that Sophia's gone through because they're honestly practically too traumatic to face. And I don't know how she endured trying to deal with it with that population for as long as she did. But these are the daily things that continue to assail the members of our population. So what we did see was that, like with the example with many of the smokers, that you gather more of the people who are smokers around you. And I even saw the phenomena with Alice that more of her friends would start smoking to be part of the cool kids crew in their 30s, which is something really unusual, right? Like we usually think if you can get to the age of 20 without starting to smoke, you're going to be pretty safe. But this didn't end up being the case. This would roll through the communities depending on the influence of kind of the primary person or the group of people. And there was just such a strong need to belong, to be welcomed, that if that was the group that was showing that, you wanted to be part of that group. It's interesting because one of the people that I worked with a few years back when we were trying to do a lot of training of quit line providers had talked about when he called the quit line, and as you can imagine, the quit line was like, well, where are the places that you smoke? Now, what can you do to not go to those places? And in his circumstance, and this is a few years back, he said, well, one of the places I always smoke at the bar. And they're like, all right, well, then you need to think about how you can not go to the bar if that's the case, right? And he came back and his answer was, no, I can't skip going to the bar. Well, is it because he's an alcoholic and he's that dependent upon the bar? No, the answer was pretty different. The answer was that, you know, as we look at social support in our world, we think of it as being in several different domains. There's your family of birth, there's your friend group, there's your neighborhood, there's your employer, and then there's whoever you live with. But if you think about it, for some members of different types of communities, not all of those groups are going to be equally welcoming. For the LGBTQI communities, there's going to be several of them that could be very unwelcoming. Your neighbors may not be welcoming. Your employer may not be welcoming. Your family of birth, as we talked about, may not be welcoming. And what that means is that we're left with fewer of those kind of branches on our tree that we can rely on to get our nourishment from. In his case, the thing that was really important to him to get his nourishment was to go to the bar where he found the people who were welcoming. And then it ends up being this other kind of like other phenomena interact with it. Just as an example, in his case, and he's a Latinx gay guy, since he was kind of cute, let's just put it that way, he decided that in conjunction with the tobacco cessation specialist, that he would stop buying cigarettes. And that would be the big step to try and make sure they stop smoking. But what he actually found out was that everybody was giving him cigarettes. And for 2 years, he continued to smoke without ever buying one cigarette, simply because, again, this was like a transactional thing in the communities as far as being part of that crowd. And also, how do you, you know, express appreciation of someone, different phenomena like that. And those are kind of things that, as a tobacco cessation specialist, are we familiar with that at all? Are we familiar with how, you know, some of the existing tools that we might talk about in our toolkit aren't going to work because there's different social factors at play for different populations. But let me also, okay, I'm going to kind of continue to go forward a little bit in this life course with Alice, because then as she started to enter her 40s, what she got was she started to see friends die prematurely. And she started to have more and more friends who were having cancer, right? And it ended up becoming a piece of a common phenomena in her communities that she would be going to funerals for friends who are dying young. So you might think for many of us, this is really motivational. We understand that when you hit one of those extreme health problems, it's one of the biggest opportunities for us, whoever we are, to think about a life course change, right? But the thing about this that was different is that growing up with this kind of social exclusion so systemically from so many places, so many people, as just another example of it, when I went to get my first cancer screening and the doctors found out that I was queer, they were so, let's just say, not gentle, that it took me about 2 days to heal from it. That's not necessarily the normal experience, but those are the kinds of poignant things that stand out as far as what can I trust and what can I not trust? And unfortunately, the truth is too many of us, and by us, I really mean not just the LGBTQI populations, but all the racial and ethnic minority populations as well, have negative experiences with the healthcare system. And even if that may have, for me, happened, 30 years ago, it still is one of those things that affects my level of comfort. And then, in addition, we can't underestimate the idea of how there's social factors here that if you haven't experienced it yourself, we know of too many friends who have, right? And that's a kind of social contagion of this fear and concern. And so with Alice, as she starts to deal with in her 40s, other people dying, one of the things that's been different for her, and we see this in the LGBTQI populations, is we don't expect to live as long. In some cases with measurements of our youth, we don't even see ourselves, like you ask you, how long you imagine you might live, things like that. Non-queer youth will say that they're going to live much longer, and queer youth, it's about 14 years shorter. So we don't have this horizon that we're going to succeed in an environment that's hostile to us. So what Alice does is she kind of starts to incorporate that into her long-term life thinking and planning. Right now, she is in her 50s and approaching 60, and she doesn't think she needs to save for retirement because she doesn't think she will ever have to retire. She presumes she will just die, and she just hopes she will, and I presume cancer could be a piece of that in her thinking, but she just hopes she goes quickly. So there's this kind of fatalism that ends up seeping in because of this lifetime of exclusion that's experienced by people. And just to kind of, again, give a little bit of what is this like in other places, I'll bring up Trudy a little bit. Trudy is an American Indian trans woman. And one of the things that Trudy experiences as a Navajo trans woman is that she almost never sees anybody else like herself. You know, I think about it even as a white trans guy, except on video, I rarely see other trans guys. And there's something that really is really destabilizing whenever any of us are in a situation where we feel like we're kind of alone, right? Because it means that, you know, you feel a little bit more like one gazelle on the Serengeti. You know, when you're alone and there's this hostile world out there, it really doesn't give you that sense of safety. And then you also see in Trudy's case, you see people that she knows are, let's say, gay. But she'll know that they're gay because she sees them out in the bars. She goes back to the reservation and they absolutely change and won't admit or talk about being gay whatsoever. So a lot of us go through a lot of different kind of performative aspects trying to navigate where we feel safe. And then of course, some of us, if you know your skin is darker, things like that, you never have the choice of hiding that difference about yourself from the general population that you're in. So I just want to kind of say those things as a little bit of what we think of might be the constructs that are these life experiences that people might be coming to us with as we're talking to them about tobacco cessation, screening options, things like that. Because I do a lot of work with providers, as the people here, saying, hey, it's important to be welcoming. And I think that most every provider I've met also thinks it's really important. You've dedicated a lot of energy and focus and time and your own money in order to become a good practitioner of healing in some way, right? And I think a lot of us want to meet this goal of being really welcoming for the people that, like these people I'm talking about, may be different than us. But what I want us to kind of think about is how is it, and I realize as we're doing this, I just noticed because of the Zoom function, I don't have my pronouns on. But how is it we do things like, for example, put our pronouns on as a way to, here, I'm gonna do it, there we go. As a way to show people that we understand a little bit about what some other communities might be going through that we may not be part of ourselves. And how is it each of us stretch our own experiences, both professionally and personally, beyond whatever our historical background is, and make friends with the people like I'm talking about a little bit in this talk, but also make sure that we have professional education related to the experiences of other populations. And how do we, when I say, you know, like it's important to be welcoming, one of the things I often bring up is that I'm more likely to see all races, all immigration statuses, all religions, all sexual orientations, all gender identities are welcome here sign in my local bakery as compared to seeing it in my local healthcare provider's office, right? Which I'm very happy that my bakery wants me to be welcome. My bakery wants me to feel welcome. But it's sad to think that the healthcare providers who are experts in healing don't also understand how important and powerful signs like that are. Because when you've got any set of people like myself who have experienced a lifetime of this kind of social exclusion and the burdens and the way we have to manage it ourselves mentally, and too often that happens with tobacco use, when is it going to be the case that we are going to go to the healthcare system and that'll be the one place we think to ourselves, oh, there's been some effort so that people feel like I'm included here. This is a place where I can feel a little bit more safe. This is a place where people have focused on educating themselves about me, where they've focused on putting out some of those basic signs so that I understand it's easier for me to be here. As again, a trans guy, and as the head of the Cancer Network, I'm super motivated to get my own screenings, right? Yet when I had to deal with a suspect thing on my back, I did not want to go to a new dermatologist, and I actually had to be pushed by my partner to finally find someone. And I don't think I found someone who's welcoming, so I need to find a new dermatologist now. So like, how many ways are we, that all puts grit in our process, that puts sand in our machine as we move towards healthier behaviors? And then how can we, as people who are really focused on changing that, expand the range of people that we're understanding and hearing about and knowing about, and how can we change our practices to make sure that when I come to you, I feel the welcome that I haven't felt in so many places throughout my lifetime and other similar people's lifetimes. And with that, I am going to wrap it up. I know I'm going to be on the panel later, but that will be the beginning.
Dr. Scout, thank you so much. Thank you so much for all that you shared this morning and for your comments. Very, very powerful. We appreciate it so much. Let me introduce you now to the person that will lead our panel discussion. We're so pleased to have with us Dr. Kathleen Goss. Dr. Goss joined the American Cancer Society in April of 2021 as a North Central Region Vice President of Cancer Control. Dr. Goss has recently been named the Senior Vice President of Partnerships and Capacity Building at the American Cancer Society. Kathy has a wealth of leadership and experience and a passion for the Society's mission. She is a longtime cancer advocate and served as a volunteer with the Society and ACS-CAN for more than 19 years before joining the American Cancer Society as the North Central Region's Vice President of Cancer Support. Dr. Goss graduated with a bachelor's degree in chemistry from the College of Wooster, Ohio, and a PhD in cell biology from Vanderbilt University. After postdoctoral training at the University of Cincinnati, she started her research program on the molecular drivers of breast and colorectal cancer, and then moved her laboratory to the University of Chicago in 2007. In 2013, Kathy joined the administration of the University of Chicago Medicine Comprehensive Cancer Center, where she most recently served as the Associate Director for Administration. Dr. Goss has been a tremendous advocate for the Society, and we're so excited to have her as our moderator this morning. Thank you, Kathy, and welcome.
Good morning. Thank you, Deb. Sorry about that long, bio, but kind introduction. So I'm thrilled to be here, and Dr. Scout, thank you so much for your remarks. You really set the stage beautifully for this conversation, as well as our, as Jim, the advocate, sharing his story. We're just so grateful to have you here, but also just provide that really well-needed context for us. So I'm really thrilled to be moderating this panel. We've got a distinguished set of panelists that I'll share with you in just a moment. But again, to further set the stage, because we're going to be talking about screening, lung cancer screening, I just want to review the screening guidelines and criteria that are recommended. So as you can see here, we advise that healthcare providers and people at increased risk for lung cancer really take a look and follow the recently updated recommendations for annual lung cancer screening. And so these are guidelines from the US PSTF, as well as the American Academy of Family Physicians or the American College of Chest Physicians. And so you can see what those recommendations are here. They all recommend yearly lung cancer screening with low-dose CT scans for people who are 50 to 80 years old and in fairly good health, currently smoke, or have at least, or have quit in the last 15 years, and have at least a 20-pack year smoking history. It's so important that in addition to this, that people who are going to be screened, that they receive counseling to quit smoking if they're still currently smoking. They've been told by their doctor about possible benefits, limits, and the harms of screening with low-dose CT. And they can go to a center that has experience in lung cancer screening and treatment. We know that high quality screening is so important. So with that, I'm really thrilled to kick off our panel discussion today. And so I'm going to ask I'm going to ask all of our panelists to introduce themselves when I ask them their first question. But I'm just thrilled you can see all of our panelists here. Dr. Jasleen Pannu, Dr. Jane Kim, Dr. Scout, NaSheema Anderson, and Cassie Bednarek. So we're really thrilled to have you all here. And again, I would love to have you introduce yourselves, tell the group, our audience here, a little about your role in lung cancer work and screening, community outreach, and health plans, whatever that may be. And then we'll jump in with our first questions. So I am going to start with Dr. Pannu. So if you wouldn't mind giving a quick introduction, and then I'll jump in with the first question.
Sure. Thank you, Dr. Goss, and everybody at American Cancer Society for having me here. I'm Jasleen Pannu. I'm an interventional pulmonologist, which means basically that I specialize in doing procedures of the lung, and I am an assistant professor at the Ohio State University Medical Center. I've been here about 5 years, and I'm passionate about early detection of lung cancer, and that's where my work has been centered towards since the last 4 to 5 years. Because we are usually comprised of the people who give the first news of cancer diagnosis to a patient after we do a procedure. We are usually the gatekeepers that may see a patient that can potentially have lung cancer, early or advanced. This is a topic that's very close to us and very close to my heart. I'm doing a lot of work in trying to build a comprehensive early detection program, or say an early detection center even at Ohio State. We have just initiated our multidisciplinary lung nodule program with a big focus on appropriate treatment of incidental detections of early lung cancer, like lung nodules. And that works in collaboration with the lung cancer screening program we have here to try to streamline access to the community, to this opportunity where anybody who ever comes to our hospital and has an incidental finding, whether they were in the ER or an urgent care, whether it was within the hospital system, if they have an incidental finding, they should get rapid access to care to address that incidental finding that could likely lead to early detection of lung cancer. And for that, we are using, of course, our multidisciplinary teams, but we're also implying machine learning tools, as well as some natural language processing as AI tools, so that we could detect these detections as early as possible. And it was important because national data as well as our data revealed that we were missing about 70% of these detections, and that's what we are working with. And lung cancer goes hand in hand, of course, with early lung cancer detection, with similar lung nodules that are detected for early lung cancer. So I'm very excited to be here and happy to learn from you and contribute in whatever way I can.
Thank you, Dr. Pannu. I really appreciate your remarks, and I think, and I would love to dive a little bit deeper in a bit about some emerging technologies, some things that you mentioned, and including biomarkers. But I would love to hear from you to kick us off in this discussion about, you know, in your experience, what are some of the top barriers to screening? And of those, are there low-hanging fruit that we can really try to tackle as an oncology community? And then are there others that we know are going to take a little bit more time and work to start addressing comprehensively?
Yes, because, you know, lung cancer screening is picking up, and not like less than a decade ago, we didn't even believe in lung cancer screening, you know. So it's just kicking off. We are dealing with so many barriers, which are, a lot of them are barriers of stepping into the unknown. So when we first mention as providers to the patients, a lot of barriers in other providers itself is the barrier of, oh, will it show me something that's a false positive, or something is just a finding that won't yield much results, but will be just an excessive work to get through. What is the risk of radiation exposure that holds back patients, as well as fear. These barriers, which are related to facts and knowledge, maybe something that can be already addressed well with the component of shared decision making and the discussion and the face-to-face visits that we have with the patient. So when I see a patient who I start talking about lung cancer screening or early detection, when they bring up these things, we know now that screening CT scans don't yield more false positive results than other screening procedures like mammograms or colonoscopies. They're actually the false positives in screening scans are actually.
I think we might have lost her for a moment. Am I the only one?
No.
No. Okay. I think we've lost her for a moment, but we are going to roll with it and hopefully come back to Dr. Pannu about some of those barriers that she's
probably big tobacco, don't you think?
Yeah, certainly.
No.
Certainly. Dr. Jane Kim, I'd like to turn it to you. If you wouldn't mind doing an introduction, and then we'll kick it off the discussion around veterans.
Sure, thank you. It's a pleasure to be here. My name is Jane Kim. I'm the Executive Director for Preventive Medicine at the Department of Veterans Affairs. I'm also an Associate Professor of Medicine at the Duke University Department of Medicine. I'm a general internist and preventive medicine doc, and I practice primary care at the Durham VA Medical Center in Durham, North Carolina. My role in lung cancer screening has been mainly in policy. VA has its own policies for cancer screening, and lung cancer screening is, of course, one of our policies. And my office actually did a pilot study about a decade ago, actually, to look at what it took to do lung cancer screening in our VA healthcare system and all the resources that would be needed to do that. So we did some very early work to kick off those efforts, and that has gone out throughout our VA nationwide network, which I'll share with you later as we go into some of the other questions that we have for this, but I'm just excited that we were there in the beginning and we're still here. So thanks for having me. And Dr. Goss, I'll turn it back to you.
Yeah, well, we're thrilled to have you as well. And you just bring this really important perspective, especially for this unique population. So speaking of veterans, lung cancer is the leading cause of cancer death in that population. So can you talk to us about some of the specific barriers that population faces for screening?
Sure. I think when I thought about this, there are two major barriers that I wanted to speak on. One is access, and the other is awareness. But I'll go with awareness first, since I think that is just something that if you aren't aware about screening, you're not going to get it. Mm-hmm. So awareness is on the part of both the veteran and our providers. Awareness that a person is eligible for lung cancer screening, as you outlined the criteria. Many people don't know that they're eligible. Some veterans might think that's only for men, not for women. They might think that I stopped smoking, so I'm not eligible. So there are just a lot of misconceptions about whether someone is eligible at all. And I would say that our providers too, there's been a change in those recommendations over the past 5 years, and may not be aware of the change in order to have those conversations with their veterans. So awareness is a key issue that we are continuing to work on, both our patients knowing if they could be eligible for screening, and our providers knowing when they open the chart, this is the patient that I should talk to about lung cancer screening. So those are two avenues that we're still working hard on to increase awareness. The second barrier that I wanted to speak to is access. And I think some veterans, I only see veterans in the VA healthcare system. And so I had to take a step back and think there are so many veterans out there who are not enrolled in our VA healthcare system who might think, I'm not eligible for that healthcare. I just have to figure it out on my own with private insurance or in the community. I wanted to put it out there that VA has had a recent expansion in who's eligible for healthcare benefits through VA. And I just wanted to encourage people who have patients who are veterans, or you might be a veteran yourself, to go to the website va.gov and take a look, because there has been just a very recent, in the past few months, an increased eligibility for many veterans, especially those who are Vietnam era and have exposure to toxic substances. But I will say access to get in our system is an issue that I hope many veterans will be able to get in now who might not have been eligible before. And also in our system, if you're in it, some people think, well, I might not have great access because my clinic is so far away. And geez, I don't want to drive all the way back for my low dose CT. We are able to refer our veterans in healthcare to community sites who have that low dose CT closer to them. So I did want to kind of dispel the thought that I would have to drive all the way back to my VA clinic to get the screen. If it's too far for you or we can't serve you in a timely manner, we can make a referral to the community and you can get the screen closer to you. So those are the two barriers I wanted to highlight for veterans.
So important. Thank you so much. And we're going to come back to you to learn some more. Dr. Pannu, and I see that you're back after we lost you for a moment. You were talking about some of general barriers to lung cancer screening. And I think it really fits in nicely with what Dr. Kim was saying about awareness. And you were talking about some of the myths and fears associated with screening and really educating. What other thoughts do you have about tackling some of those barriers?
So yes, and I find the ones that are based on probably less knowledge, slightly the low-hanging fruit to handle, because they can be filled with knowledge and the myths can be busted like that. However, the larger barriers and that need a more systemic work and more society are based around stigma and the financial burden behind trying to get basic lung cancer screening. I think that holds a lot of people back, even to bring up or to be open to the idea of screening for lung cancer when there is bias or a differential behavior that feels sometimes from even their family members, or as well as physician providers, as well as the healthcare system. And when we feel that, when screening is selective towards certain people, it feels almost like a blame of, hey, you put yourself through this, so you need screening. And, instead of empathy, it's a lot of justification that the patient gives, regarding their prior history of smoking, which I feel is odd because this is not seen in other screenings. You're not initially or certainly instantly trying to explain yourself for being eligible. So I think that is very deep rooted on every level, even in the patients themselves being discriminated against themselves. And a lot of the burden of lifting the stigma goes on us as providers to talk about these things and to normalize talking about this, just like a mammography, just like a pap smear. And then of course working on a systemic level is the big barrier. It's the financial barrier, and not having accessibility or being open to Medicaid covering these in some states still, these screening scans, and some patients still having to pay at least a part of it. They will set it behind if they're already backed up financially. They can put this behind for a few years and rather do something else, especially because it comes with so much burden of fear and stigma. So I think that is something that we have to work on a systemic level that may be harder, but that's why we should gather like we are now, so to try to find solutions.
Exactly. Thank you so much for that perspective. And it takes us all collectively to tackle some of these challenges because frankly, the screening rates are just abysmally low across the nation. Dr. Scout, I'd like to turn it back to you. You need no introduction because from earlier, and thank you so much. Your remarks were so powerful, and we appreciate you sharing your story. I especially appreciated you talking about your screening experience. And given the specific challenges that the LGBTQI population faces when it comes to screening, you know, those barriers are unique. And so what are strategies that are being developed to address some of those barriers? Can you walk us through that and what we can do as an oncology community to address them?
Sure. Well, you know, the first thing I'd say is, while I think they're unique, again, they're facets of the same kind of phenomena experienced by a lot of different underserved populations. I mean, they may bake themselves into a slightly different flavored cake, but it's the same basic ingredients, right? And so, you know, we have to think about how have people had challenges with the healthcare system throughout their whole life, and, you know, including, as was being talked about, when this is a type of screening that relates to an activity that, you know, you could have avoided. We, you know, I think as in people's minds, we realize, you know, it's a pediatric epidemic. The people who are usually touched couldn't have avoided it, right? But there's more of this guilt, like who wants to, if you've been smoking your whole life, who wants to learn the lesson of what's hiding behind that, what's going on in your body? Like that's actually something you're kind of trying to avoid to keep your choice to pick up that next cigarette, you know, make sense to you cognitively, right? But, you know, I think that the steps related to this are pretty clear. The first thing is the more we can do to find anybody a medical home. Like I was just even looking up what the lung cancer screening guidelines were right before this. And we know they're complicated. They're so complicated that most people can't easily understand them, which is why we need to have, like, you know, you're going to have one mechanic for your car who tells you when the timing belt should be changed. In the same way, we need to encourage people, particularly from underrepresented populations, to get to that medical home. So you have that mechanic for your body and life too, who can translate the complicated guidelines and also push you, like my provider pushes me. Like, look, you need this screening. I know it has to do with the body part you don't think you have, but you still need the screening. So I'm sorry, but we're going to talk about it every time we see each other until you actually get it. So the first thing is really encouraging that building of the medical homes, which for a lot of underrepresented populations is FQHCs, safety net places, things like that. But then beyond that, like, how do you actually make that kind of welcome for different populations at your own place? I encourage people to actually lean into getting more cultural competency and cultural humility training for different populations. I also really encourage you to build friends among all these kind of different populations, because that's really what makes it salient for you in your life. And it also makes all these learning experiences, things that you're doing, you know, like whether it's, you know, you're hanging out while bowling or something like that, you know, you end up getting more of this information about how other people see the world. But then also look at, you know, what do you have on your web that is welcoming to underrepresented populations? You know, I can't tell you how many cancer centers we go and I'll just search, oh, bisexual. Absolutely nothing comes up, you know, and we know from, there's only a little bit less than half the NCI level cancer centers, which are best in class, right? Who even have anything about LGBT in their non-discrimination statements or their Bill of Rights. That's absurd that it's not even in non-discrimination or Bill of Rights. So that's a loud message of non-safety, right? So how can you put those messages of safety? And the nice part is, you know, with a lot of places we work, you're gonna have a bunch of pages on your web. Fine, have one of them be for this population. Have another one be for this population. I know we are developing sample language other people can copy. The other cancer and tobacco disparity networks that CEC funds probably have the same thing. And then how do you incorporate those things into your physical experience too? Like, am I going to see a sign like at the bakery when I walk in? Am I going to see people putting pronouns on their lanyards and badges? Not saying that you're a part of the communities, but saying that you understand the phenomena of people who've been discriminated against and experienced social exclusion because people presume that they're a pronoun that they're not, and it really distresses them. So instead, you can put your own pronouns on, and that's a great way to just be like, okay, if you feel like telling me yours, you may think it's a little safer to do so. So I just really want us to consider in all of our, you know, practical steps in day-to-day interactions, business as usual is not fixing the disparities. So what can you point to for any population that you're doing that's not business as usual to help increase people's sense of safety? And that also includes actively hiring from underrepresented populations. I mean, I think that's one of the very best ways that you can actually build comfort and security. And then not just hiring as tokens, but valuing the diversity of those hirees. If you're in a large organization, encouraging them to form a specialty group to help assess your practices overall and give you many more strategies and suggestions for the rest of the practice.
Thank you. I mean, that really practical, straightforward ways to be more inclusive and to address some of these challenges. So
hang up a rainbow flag too.
Yeah.
Don't only do that, but like, just the concept is at least be starting somewhere.
Yes. Yes, exactly. All right, terrific. A reminder before we get to our last two panelists, a reminder that you can put questions in the Q&A box. We will get to them in a moment. I want to make sure that we get to our other panelists before hitting some of those questions, but keep them coming, and we're going to continue the conversation. So I'm next going to go to NaSheema Anderson. NaSheema, do you mind introducing yourself, and then we'll jump into some questions.
Sure. NaSheema Anderson from the Community Outreach Team at the Cleveland Clinic Foundation. And a little bit about us is that we have been in existence for over 15 years. I have been in the department 6 years myself, and we are tasked with going into the communities and attempting to eliminate late-stage cancer presentation and improve overall survival through education, screening, and access with our concierge patient navigation program. And we aim to reduce disparities through education, early detection, and navigation within underserved communities. So a lot of what has already been spoken about today is our mission and vision for our community outreach team. So we serve high and urban populations by educating and giving them evidence-based screenings, which lung cancer is one of them. We focus on 5, but lung cancer is one of them. We want to ensure access to patients, regardless of their barriers, an inability to pay, so they don't have insurance or transportation. And we try to work through our healthcare system. We know that it's a big system and it can be scary to navigate. And so with our lay navigation team, we try to better increase access, healthcare, education, recruitment, and hopefully decrease late-stage cancer diagnosis.
Fantastic. That work is so important. And these kinds of efforts, are critical to moving the needle, as you've outlined, and learning from the successes and opportunities and best practices is one of the reasons we're all here, right? Is to learn from one another. Can you share with us any of the approaches that you've all taken and had success with? What outcomes have you achieved? I know you talked about navigation and a few other things, but I'm just curious. This is hard work. For people that don't do this work, it is really hard work. So I would love to hear more.
Sure. We always say that everybody wants to be a part of community outreach until it's time to be a part of community outreach. That's our slogan. We took a multidisciplinary approach by being able to be in the community, but working with our lung cancer team, because as it's been mentioned, the dynamics are, the screening criteria is difficult. And so you need somebody to explain that to you and then explain to you why you need that. And so we merged our big hospital with our FQACs and partners that were really invested in having their patients screened for lung cancer screenings. And so we made a very seamless process of how, once the patient saw their provider in the FQHC setting, made a very seamless process to making a referral to our team, and that patient being navigated by one navigator through the entire continuum of care. So financial clearance, transportation, setting up the shared decision making, all the way to the CAT scan. You move through the system with one person after you made contact with whomever told you that you might be eligible for the screening. And we found that particular practice, with all of us engaged, really showed tremendous results. We went from, which is embarrassing with this large crowd, with almost no screenings a couple of years ago to almost 70 this year alone. And so right now, dealing with a patient who just recently was diagnosed with lung cancer, does not have insurance, but he's working with his particular navigator to take him through the continuum of care. And so he doesn't have any reservation or fears. He just needs to focus on getting better.
Wow. I mean, hats off to you and the team. And that's exactly how to make it happen, is digging in and really investing. So I'd love to hear more, and we'll come back to you about some of how you've made it all happen, because I know it's not, you don't just, wave a wand and it all comes together. But let's turn to Cassie Bednarek first, and talk with her a little bit about her role and work that she's doing. So Cassie, if you don't mind introducing yourself.
Yeah, thank you. So my name is Cassie Bednarek, and I am a population health lead for Ohio's United Healthcare Community and State Plan. And so a lot of the work I do is utilizing data and our quality improvement science to really just improve the health of all of our members. And my stream specifically is focused on really that preventative care and preventative screening aspects. And a big chunk of that is the focus on tobacco use screening and cessation efforts. So I'm excited to be here and kind of share the perspective from a managed care organization.
Thank you. It's such an important perspective. So we're really thrilled that you joined the conversation. So I would love to hear from you specifically around, uptake of tobacco cessation, and what are some of the barriers that your members face when it comes to reducing their lung cancer risk and really uptaking cessation strategies. I know it's so important, but often so difficult as well.
Yeah, so I think there's really a few barriers that we've identified that even go beyond just the member. Mm-hmm. And I think the first is being just the identification process itself of members that utilize tobacco. And the second is that education and awareness piece of not only the risks of utilizing tobacco, but also, what is available in regards to cessation resources. And we really look at both of those pieces from the provider and the member angle. So with that identification piece first, that really is a big focus here at UHC. So we really need to know the members that need help before we can give them the appropriate tools and support they may need in their tobacco cessation journey. And that really ties in with the screenings. So that really means working with our providers to make sure not only are they screening, but that they're billing and documenting appropriately so we can see from our end and really support both providers and members from that aspect. And I think this also means making sure we have providers and not just our primary care providers screening and being willing to have these conversations. So things like your OBGYN, your dentist, your pharmacist, really just trying to cover all the bases from all the provider angles. And I think that really ties into the second area of, education and awareness. So from the provider end, again, we're really focused on providing knowledge of billing codes and documentation process, especially for, our Medicaid line of business. And that really helps with the identification piece. So then when they do have these conversations with members, also just ensuring that the providers are aware of the resources that are available for our members. There's a lot of great tools out there and it can be hard to keep track of them all. So we really focus on, providing support through our providers in that way. And really focusing on making sure we have the right resources for the right members and those needs. And then looking at things from the members side, this really can be quite challenging. I think for a lot of tobacco users, it can be hard to not only accept that, there may be a concern with the tobacco use, but then also the next step of being ready and willing to change. And that's where education is really huge for both of those pieces. So we really focus on providing education from multiple sources. So, things like having those conversations with your providers, mailers, texts, our case management team, really just trying to hit the members in all aspects and various settings of their life. And this directly ties into some of the more social aspects of it. So, talking about like access to nicotine products and social acceptance of those products in the communities. We really do take a community focus. So where are they getting these products in the community? And so really just focusing on that piece, and also that ties in directly with some of the social determinants of health. And then lastly, when they are ready to quit, just making sure we are educating them on resources available. And that's a big focus, making sure we have a wide variety of tools to fit a wide variety of needs and members. So things like phone screenings, reward programs, and various local and community resources and events, and even telehealth. So really just making sure we have all the tools available and accessible to all of our members and all of our providers as well.
Wow, really comprehensive approach, which is critical, right, to attack this from all angles. So thanks so much for sharing that perspective. And I know I've got some follow-up questions for you. And I also appreciate that several of you are answering questions in the chat as we go. Really grateful for that. I'm going to turn it back to Dr. Pannu. I would love to hear, you mentioned technology and the use of AI and other tools. Can you talk about what is the role of emerging technology in lung cancer screening, and including things like biomarker testing, and how can we accelerate progress on that front? It feels like we're really at a precipice where, the need is so great, and we've got incredible amounts of data and tools and technologies, but how do we sort of move the needle with some of those advances?
That's a great question. So emerging technology, including biomarkers as well as machine learning tools, because they can provide a solution to all these barriers that we're talking about. So use of biomarkers, for example. So biomarkers is essentially based on the theory that several areas of the body, except the lungs, carry an imprint of the fact that you may have lung cancer or early lung cancer. And that may include doing a nasal swab, where you may find some proteins that may be indicative that you're carrying some genes of lung cancer or predisposition to get lung cancer, or a blood test, or even so great would be a breath analyzer test, that if you could just blow into a machine, and if that would be screening, because that could, one, lower the cost of the current method of screening, which is CT scanning, and make it more and more applicable to wider populations, as well as improve accessibility. And once the cost is lowered, you could lower down barriers of restriction, that only this population is eligible right now, and you may not need that much of coverage issues with Medicare, Medicaid, and all different private insurances to try to justify a low-cost test. As well as it may be used in our current scenario, where if we are concerned about, say, a false detection, or we are concerned about an adequate treatment of a smaller nodule, which detection is the one that we should go after more aggressively? Which detection should we hold back on at this point? How can we avoid aggressive procedures and proceed to the more risky lesions first? You can use these biomarkers as a way of refining your decision making. If you have a positive screening scan, and on top, if the biomarker is negative, maybe you can observe that spot for some time, versus if you have only even a 5 or a 6 small 5 or 6 millimeter spot. But if the biomarker testing is highly predictive or at a high range, maybe we should approach that more aggressively. So that's where the role lies, and because of the impact it can make on large populations, because of how much accessibility it can open up and how much the cost it may lower at some point, the potential it carries is huge in terms of biomarkers. And there are some commercial biomarkers already available that are covered by Medicare regarding patients who have lung nodules, even if they are small. And these are validated and now, like I said, commercially available for use too. They have their patient assistance programs, which helps to make them more accessible. I think where we lie in terms of those issues is that I think there's not much awareness of their existence as of yet, and there's less awareness of what to do if I get a result, what to do about it. So I think there's a lot to do regarding speaking to primary care providers, even people who are ordering the screening tests, as well as seeing nodules regularly in their clinics, to speak to them about how these biomarkers can be used in their general practice, so that there's not that fear of unknown about it. So a lot of that is needed, spread out events regarding this. Biomarkers regarding screening are also underway in testing. They are not yet commercially available, but they are available under trials right now. And over the coming years, there's a lot of work being done in trying to get them into mainstream to see if they're sensitive enough to match CT screening or more. And then I'm going to comment some on the machine learning or the AI. And AI and machine learning is important because as we are expanding the populations that are eligible for screening, it becomes our responsibility to who we screen that we follow them up properly. And screening tests, if we are expecting people to get yearly screening tests, there has to be a way of telling them you're due for your screening, come in. It should not be the onus of the patient to keep a record of, hey, I'm this criteria now, meeting that criteria. Can we automate these systems? And a lot of automation does exist for mammograms and pap smears, and they are sort of normal word of the land in managing these patients. And the same needs to be approached for lung cancer also. And also because the numbers of these detections and the numbers of lung nodules and the scans that we are already dealing with is massive. It runs in millions. And to think that these can be maintained on Excel sheets and patients can be reminded of forgotten appointments. And if we really want to increase our numbers and increase our reach, we have to tap into tools like automated softwares and machine learning that can be used for management of patients and sending reminders as well as their follow-ups. So that's where that becomes important. Radiomics is something that is also a part of AI, which means that if there's a nodule or the detection made on screening scans, the scan itself or the computer itself can look at the nodule on how it looks, and based on how it looks on CT, there can be prediction of whether this is benign or malignant. But in a very we need it to be in a very highly accurate level so that it can be reliably made and not just sort of an average prediction. So there's work being done on all these fronts, biomarkers, radiomics, as well as automated patient management systems, in trying to manage this huge database of patients so that we are able to propel this forward also to reach almost everyone.
So a hugely important set of tools that are in our toolbox. We just need to learn how to use them well and make sure that all patients have access to those tools, all providers and patients have access to those tools. So exactly. It's an exciting time, but we've got a lot of work ahead. Thank you so much for that perspective. Dr. Kim, I want to turn it back to you about your work, and you mentioned some work in the for veterans and increasing eligibility. And I would love to hear more about that and why that's important, eligibility for screening. I also want to get your take on policy-based changes that can really help us accelerate the uptake in screening in this population and others. If you wouldn't mind talking to those points.
Sure, and those are great questions. I will say that VA internally, as I mentioned, does have a policy on who to screen for lung cancer. That is the same as the U.S. Preventive Services Task Force. So the 50 to 80 year people with 20-pack year history, current smokers who quit in the past 15 years is the eligible population of veterans who can get lung cancer screening. So I know there was a good question in the chat about that, and I just wanted to put that out there again, that VA does follow USPSTF for this policy. I will say in terms of eligibility, that is something that I'm very excited to share that VA is moving forward on just in the past few years. I guess fortunately or unfortunately, the VA's efforts to expand lung cancer screening and eligibility coincided with the pandemic. So we're still trying to get things off the ground because you can't get a low-dose CT scan virtually. But that being said, you know, after VA did an initial pilot to demonstrate feasibility of doing lung cancer screening at its networks way back in 2013, lung cancer screening, to be very honest, kind of trickled along. We found in 2019 that only 10% of veterans who are eligible based on criteria for lung cancer screening actually got it. That's a very, very low percentage. And so in response to this, VA, as a part of its precision oncology program, which is a part of the White House Cancer Moonshot, stood up a lung cancer precision oncology program. That is a program that's separate from mine, but I work very closely with them. But they are all about organizing VA's program of screening in our set of networks across the country. So VA has 18 regional networks, and we are putting screening expertise and implementation expertise in each of those regions, and having those regions decide how to best roll that out, whether it be there be a hub site where people can get lung cancer screening in that region if it's a smaller region, or maybe to have that expertise available at one site and to have them train their other sites in the region to do the same. So that national precision oncology program specifically for lung cancer rolled out in 2020, again, coincided with the pandemic, but they have done a ton of work to kind of get the people trained in each region on how to do lung cancer screening. As was mentioned by some of our other panelists, it's incredibly complex. You could say, oh, well, if you're eligible, just get the low-dose CT. Well, what if you find something else? How do you know to come back next year if you didn't find anything? So just to make sure our patients are safe and tracked, we're rolling out national tracking systems, teaching people how to use them, putting a lung cancer coordinator in each of these regions, and hopefully more than one, because there are a lot of veterans who could be eligible and need tracking. So all the systems, things in place to help our veterans make sure they get offered screening and followed up appropriately. That is all underway, and I'm so excited about that. It's been a long time coming. It was a dream to hear that it was actually going to go live, and we're about 2 years in, and I think they are right in the thick of getting things launched. So I did want to share that as some exciting news for those who have access to VA healthcare, that we have kind of a robust dissemination of lung cancer screening across our nationwide network.
That's incredible. Congratulations. I'm sure that took almost a Herculean task to get that up and running, especially through the pandemic. So fantastic. And you mentioned the 10% screening rate of eligible individuals at the VA. I was at a national lung cancer roundtable summit on screening, and the numbers I heard were between 0.5% and 15% across the country. So that 10% isn't so bad when you look at it in that regard. But then obviously the work that you're doing as a system is going to pay off big time in increasing those increasing those rates, but it just speaks to the need for collective action on this issue. So thanks so much for sharing that. Dr. Scott, I want to turn back to you, and you mentioned tobacco use in your remarks, and I want to hear a little bit more about the role that targeting by tobacco companies of the LGBTQI population, what role that plays, and are there strategies that have been successful that have been useful and successful in decreasing tobacco use in this population? It clearly is a major challenge.
Yeah, so it's a great question. We do know that we have historical evidence of targeting going all the way back to the early 90s. And interestingly, the tobacco industry, we can see from a case study in California, which just happens to have more of its information documented. The tobacco industry didn't want to be seen as targeting minority populations, but they had no problem with targeting the queer population. So it was interesting how we didn't even raise to the standard where they were concerned about targeting us. And they recruited one of our big community leaders, and they paid him to talk about what kind of messages would move us. And he was clear. He's like, we're not naturally going to support the tobacco industry, but we can be neutralized to take a position against them if you incorporate our civil rights messages and blend them with tobacco messages. Mm-hmm. So it's kind of like freedom to live, to love, and this is actually quoting an ad, to smoke, to inhale, things like that. So, you take the first half of it, and that's things we really care about with civil rights, and then you happen to blend that with what the tobacco industry really wants. But you also, in addition, as we know, they've got a fair amount of money. You also buy a bunch of ads in a bunch of our media outlets. And through the years, we have really struggled with our media outlets saying, like, don't take tobacco industry funding. And the sad truth is several of the outlets have said to us explicitly, we'd close if we stopped taking tobacco industry funding. So a piece of this that we have to remember is, as we're in the tobacco control community, what are we doing to try and neutralize some of that by offering, like ad opportunities and things like that to local media outlets? We know from some analyses that have been done that if you are a consumer of queer media, you are much more likely to see positive or neutral editorial mentions of smoking than you're ever likely to see negative ones. And then you combine that with the fact that you're also more likely to see these actual tobacco industry sponsored ads. And, again, it starts to, like, all the bricks are stacking themselves up in the places we don't want them to be. And then, you add pride sponsorship. And that's something where, I've worked with a lot of different tobacco control states. And usually I go through with them and I'm like, look, here's what your local pride sponsorship is. And truth be told, it's small peanuts. We're cheap. And so, I really encourage anybody who's interested in this to make sure you're also doing, and it doesn't even have to be paid. You don't have to have resources. In North Carolina, they just sent their people to the Pride Parade to be in it every single year. They got someone with a convertible, and then they were known as the Quit Line Ladies. And literally one year when they tried not to go, the Pride people got upset because they really wanted their Quit Line Ladies. And again, they also, several of the people there weren't even LGBTQ. Many people Prides are not. So you don't have to be a member of the communities. You don't even have to have an advertising budget to kind of reach out and put a stake in some of our visible events for tobacco control, that just hasn't existed, because when we're not there, it means it's a free rein for the tobacco industry to be there instead.
Yeah. Wow. Really important perspective, and so much work to do. It feels like, David versus Goliath to some extent.
I did want to say one last thing is also, if people are interested in more training on cultural competency with this subject, we actually launched a really big in-depth training series. It's full CEs, and it's all free through the end of this calendar year. So if you're interested in that, it's state-of-the-art, cutting edge. It's all online at your own pace, all that sort of stuff. And you can see it on our website. It's called Welcoming Spaces. So I really encourage you, if you're interested in learning a little bit more, to take that and or share it with other people in your institution as a free resource.
Fantastic. Maybe can we have someone put that in the Q&A box, maybe just a link to that? So that would be really helpful.
I can do
the
that.
group.
How's
Thank
that?
you so much. That would be perfect.
Yeah.
That's fantastic. I think those resources to help providers out there are really, really welcome. Thank you. NaSheema, I'd love to go back to you and talk about some of the work that you are doing and you described. And you mentioned partnerships and with FQHCs and linking them to care after, say, a positive screen. Can you speak to what role other community partnerships play in this work? You talked about really multidisciplinary, multi-level engagement, and tell us how you've been successful in making those partnerships really catalyze change in the work that you're doing.
Sure. Yeah, I think that one of the biggest things is the partnerships bring patients. To Dr. Scout's point, they bring marketing. Everybody can learn from one another. I was just thinking and jotting down some ideas of things that we have done that I would like to have shared with this team, because we need to identify with the different populations that we serve. And so we've done a couple of things where we've quoted things like blow bubbles, not smoke. And so everybody's gotten bubbles, or smoking is a drag for our LGBTQ Pride Month. We have tried to just identify with our partners how to target the specific populations of patients, and then include them and to making those referrals to us so that it's a streamlined process. I think that getting everybody on board, that there's one team that's going to make sure that your patients get their screenings and then put them back where they came from, was the biggest play, because everybody wants to hold on to their patients, and we had to strive forward to make sure that everybody understood that we were all in this together. And that was difficult because you have the patients and we have the access. And so how do we blend those two things together? And I think a combination of a lot of role defining, we made sure everybody knew whose role was what, and gave 100% access, and making sure that our metrics and numbers were visible for everybody to be able to ask questions and provide input and feedback.
Yeah, that's knowing sort of controlling expectations, roles and responsibilities, accountabilities, that's also important. And, I applaud you for the effort of you and your team for that hard work. We've just got a couple minutes left of time for our panel discussion. I don't see any questions in the Q&A, but certainly if there are any remaining ones, we can ask them of the group. I'm going to go back to Cassie for a moment, and just, you talked about identifying those at risk based on smoking behavior, for example, are so important to you and the work that you're doing for your members and providers. Can you tell me about the implications of for screening for tobacco use? And obviously we know that's an important consideration for screening, but I know there's also concern there then about health plan coverage, premiums, that kind of thing. Can you speak to that a little bit?
Yeah, so I'll start by going back to kind of that identification piece again, because we do see really low screening rates for our Medicaid members, especially compared to the general population. So we are really working with our providers and provider groups to ensure that they have the appropriate insight to what's going on with the patients at their practices in regards to tobacco use and screening. And so just one of the approaches we are testing and building out is really creating a dashboard for providers. So this not only gives insight into tobacco utilization from our members, but also how they're doing screening wise. So that could look like giving them, you've screened X% of our members this month. And then we also relate that back to some some of the money tie and piece of it and reimbursement rates. And also we are sure to include things like reminder of the billing codes. And I think we do all this from the approach of understanding that providers have a lot going on and a lot of obligations when they meet with patients. So anything we can do to lessen the burden for them so they can give the best quality of care to our patients. I think that's our ultimate goal with that. And we've gotten some really good feedback with some of our pilot efforts with that. So we're excited to continue to expand that. And then going back to the piece of, coverage and premiums, that is something we work with ODM a lot on is, constantly updating what's covered in regards to not only services, but like screenings and counseling and a wide variety of that. So they do cover a lot of great services, and we are constantly working to update them and make sure that providers and plans are aware of those updates and coverages. And so that really includes a lot of things like counseling, and that can be group, phone, individual. And that also includes things like nicotine gum or patches and things like that. So we're constantly working with ODM to make sure that we have a wide variety of coverage for our members.
Great, thanks for sharing that, because I think that can be overlooked. And I think some of it is just not knowing what is out there and what coverage is. So thank you so much for talking through that and all of the work that you're doing to support screening for your members, but also provider education and making things easier for them. I think all of the providers on this call will certainly can attest to how important and appreciative they are of that. So I think I know we're running short on time. There are a couple of questions. And it looks like we're getting some answers from our panelists typing in real time. So I think with that, and I know we've had some trouble including the link that Dr. Scout mentioned. We're going to send that out in a follow-up so that you have that. But I think, there's just a challenge with getting it in the Q&A, but it's welcoming spaces. And I'm guessing it's cancernetwork.org, welcoming spaces. Probably if you Googled it, you can find it, but we will send the link. Deb, I think that wraps up our time for the panel. So I'm going to turn it over to you.
Fantastic. Thank you so much, Dr. Goss, and thank you to our panelists. What a fascinating discussion. Literally, we could listen all day, and I think we wouldn't get to all of the information that you have to share. Absolutely critical. Thank you all so much. Before I introduce our next speaker, though, we're going to take just a moment to have our third poll question of the morning. You will see popping up on your screen, challenges to lung cancer screening. The question is, what do you observe as the biggest barriers when it comes to lung cancer screening? This is a multiple choice question, and you may need to scroll to see all of the options that you could choose. So I'm going to pause just for a moment and allow you to read the question and make your selections. When you're completed, hit submit, and then I'll introduce our next speaker. So we'll take just a moment to complete the poll question. And if you're wondering, when we do the polls, it helps us to build future forums. So we would love to have your input. It will help guide and direct what are the topics that you would find most interesting. While you're finishing that up, feel free to make your choices. I'm going to begin to introduce our next speaker for you. Emily Reising will be our next speaker. She's from the American Lung Association. Emily is a health promotions project manager with the American Lung Association. She's worked on multiple projects with the Lung Association and most recently started as project manager for the Improving Asthma for All project, which is a 5-year initiative across 21 states. It's focused on improving asthma among adults and assisting with tobacco cessation when appropriate. Emily earned her Bachelor's of Science and Master's of Public Health degree from the University of Illinois in Urbana-Champaign. She lives in Lakewood, Ohio with her husband and her 1.5-year-old daughter. Emily, thank you for taking time to join us this morning. I turn it over to you.
Thank you so much, Deb, and thanks for having me today. There's been a lot of really great speakers this morning, so I'm glad to join you. I just want to take a couple of minutes to talk through some tobacco cessation programs that we have available nationwide, but especially some extra offerings for Ohio and West Virginia. So we can go ahead and advance to the next slide. Thank you. So I want to highlight 2 of our kind of bigger programs, but we've got a host of other programs and resources available, and I'm happy to answer any specific questions. I will put my contact information on the last slide so you guys can reach out to me. But I want to get started with our biggest signature program related to tobacco cessation, and that is Freedom from Smoking. This is a program that's been around for over 40 years. And of course, we have reevaluated and updated our curriculum and process as the tobacco landscape has changed. So of course, we included e-cigarettes as they started to become popular and a big problem. But this is a program that we have specifically for adults over 18. We do qualify it for adults because it includes the discussion of NRT medications. We do have youth programs as well, and those are fitted directly for that youth population. But in Freedom from Smoking, the group program typically consists of a group meeting over 7 weeks. So it's 8 meetings in those 7 weeks. And the real focus is on how to quit, not why to quit. So this is a voluntary group that people are choosing to join to be able to quit. And we want to assist them with how to quit. So the program is set up in kind of 3 phases. Participants come in and learn some tips and strategies on how to quit. They don't quit until halfway through the program, so they don't have to come in and drop everything right in that first meeting. They quit in session 4. And then sessions 5 through 8 are all about maintenance. So once they've made that quit step, we want to be able to support them and give them more strategies on how to stay quit and maintain that lifestyle. So we're really trying to support those participants all the way through that process from beginning to end. We've seen here, you can see some points from evaluations that show participants experience immediate and long-term health benefits going through this program. They learn to address and overcome the physical, mental, and social aspects of their addiction. As some of the speakers have touched on previously, it is all 3 of those combined. So a lot of people only think of 1 or 2, but we really want to address all 3 of them. And then participants that go through this program are 6 times more likely to be tobacco-free 1 year later than those who quit on their own. They're really getting that support and those strategies and really why it's important and how to be successful. Typically, this is most often run in a group setting, but we also have an online version as well as a self-help guide, and you can get support through our tobacco quit line, our lung helpline. So we're really wanting to meet participants where they are. We understand that the pandemic has changed things, so facilitators are leading classes virtually as well. You can go ahead to the next slide. Something else I want to talk about today is our Ask, Advise, Refer to Quit, Don't Switch course. This is a course that we try to get every provider to take because it really prepares you for having those successful brief interventions with patients who are tobacco users. That includes e-cigarettes as well. So this is based on the CDC's model. And again, it is offering tools and strategies for conducting those brief interventions to really be successful and confident. We know this is really important to discuss with patients, that tobacco use and how to stop that tobacco use and where to refer them, but not everyone is confident in having those conversations and really making that more of a discussion than just a checkbox that you are going through on those appointments. So this is really useful. It's very quick. It's just an hour. It's free. It's typically available on demand, but we do also offer live webinars. I want to talk about that in just a second. But it also has one free CEU or CME attached as well. So we really want to encourage providers to go through this course so that they can be confident and successful in having those conversations. I've included the link there, but it's pretty easy to get to. It's just lung.org/ask-advise-refer. And I do want to talk about that live webinar on the next slide, please. All right, so as Deb had mentioned in my quick bio, I am part of a 5-year initiative project. And while most of it is surrounding adult asthma, we are very aware that unfortunately a lot of adults with asthma use tobacco products themselves or live with someone who may be using tobacco, and that is just exacerbating their symptoms and their asthma. So we really included tobacco cessation as a focus of this project because we want to address both issues. And if we're addressing asthma, but we're not addressing that tobacco that they're around, then we're not making anything better. So this current work focuses on a lot of things that go into that asthma that adults are dealing with. So we wanted to offer some things to make this a little bit easier to get professionals involved. So that Freedom from Smoking program that I discussed earlier, we have grant funds to support new facilitators going through the training. So while that's typically a $400 value, we can offer that training for free. New facilitators would also get their 10 first participant workbooks for free to get that first class off of the ground and being successful. We also have access to our online program, which is Freedom from Smoking Plus. We have those memberships available for free. So individuals can join, they can go through at their own pace. They do have access to the program for 12 months, so a full year once they get started. So once they quit, if they want to revisit the curriculum at all, they are welcome to do so, but it's always available to them and it follows that same curriculum that the group program does. We also have some webinars available. So Tobacco Basics is a course that is available for professionals, but also individuals who may be tobacco users themselves or live with or know someone that is a tobacco user and they want to learn more, or they want to learn more and be able to help that individual on their quit journey. So it's a very basic course, but it's got a lot of good refreshers for those of you who may already know a lot about tobacco. We have that on demand all the time, but we also have a live webinar. It's actually tomorrow. So if you'd like to join us, that link to register is here. And we also have a webinar next week. So this is that Ask, Advise, Refer course. Because it's Lung Cancer Awareness Month, we are highlighting CT scans in that webinar as well. So there's going to be a part dedicated to getting checked. Our big push is Saved by the Scan. So we'll be discussing that along with the Ask, Advise, Refer training. So that one is next week. So both of those are available for free. They've both got that CEU attached. So it's really a win-win for attending, a little bit more education, free CEU, easy for everyone. So those links are here. I'm happy to send you more information on any of those. Again, my email will be on the next slide. But I also wanted to point out that handy little QR code. Oh, can we go back just one second? That handy little QR code down at the bottom of the screen, that will take you to the page for the Improving Asthma for All initiative. So you can always go back and check out the scholarships that we've got available, the webinars, everything that is available through this initiative to learn more about what we're doing currently. Again, it is covering 21 states for the next 5 years. West Virginia is a target state for this year. So we are running through a lot of promotion until the end of December. And then in 2023, we will switch into Ohio. So a lot of good focus on these two states that we know really need support in the asthma and tobacco cessation world. So ask you to check that out. Check out the webinars, or if you can't make it for those two dates, we'll be hosting more in 2023. And again, you can always see them on demand online for free. Now we can go to the next slide. So I just wanted to toss in my contact information here, contact information for our project, and then that website there is linked as well. Went through quite a few things here really quickly, so if you want to follow up with me, I am more than happy to point you in the right direction or answer any questions about what we offer for tobacco cessation and what we offer for the project.
Emily, thank you so much. We're so grateful to have you with us this morning, and we always appreciate what is happening with our friends at the American Lung Association. So thank you very much.
Thank you.
We have one more speaker that I think is going to bring us some fascinating information, and this is Andrea Radford. Andrea is the American Cancer Society's Senior Program Manager for Tobacco Control. She holds a bachelor's degree in biology from Tennessee State University, and after moving to Indianapolis, she attended IUPUI to study public health. During Andrea's master's studies, she interned in Kenya and worked on the AMPATH project to reduce mother and child transmission of HIV. In 2010, she was awarded the Master of Public Health with concentrations in epidemiology and behavioral health. Since graduation, she's worked in the areas of infant mortality, STD prevention, violence prevention, health disparities, and cancer prevention. Andrea's passion includes working to improve health and wellness of disadvantaged populations and preparing the next generation of leaders. Welcome, Andrea. We're glad you're with us this morning.
Thank you, Deb. So good morning. I've had the pleasure of working with West Virginia and Ohio on a new project to me. So ACS and ACS CAN has recognized the need to reduce tobacco use in the states with the highest rates of tobacco use. And Ohio and West Virginia happen to be in that list, as you can see here with the map. So our work here is working to advance and implement fact-based Ohio tobacco control policies. So we're working in these 13 states, and Ohio and West Virginia are two that I have the pleasure of working with. So next slide, please. So how do we get to the 13 states that were listed? So based on the data in these states, 21%, at least 21% of adults smoke compared to 12.5% of adults in the rest of the United States. We also have identified that health outcomes in these states are relatively poor compared to other parts of the country. And income here in these states is nearly 25% less than other residents in the United States. So based on a couple of those social determinants, we have selected these 13 states. Also, we're looking at the policies that are in place in the states. And only 2 of the states in the 13 that I listed, which is Michigan and Ohio, have smoke-free workplace, restaurant, and bar laws compared to the rest of the country. So these are states that we know need a little bit more attention, and we're excited to do so. On the next slide, we'll talk about what we're doing. So we're looking at 4 topics here related to tobacco control. One is funding. So we're working to increase tobacco prevention funding and cessation for the different programs that are put out through either departments of health or in local communities. We are also looking at the Medicaid coverage. So what we have found out through the data is that tobacco cessation is more effective when it is a dual coverage. So meaning that we're going to have people that are doing counseling as well as using medication. So we're working with Medicaid programs to ensure that there is a comprehensive coverage, including individual, group, and telephone counseling, as well as all of the approved medications, FDA-approved medications for tobacco cessation. We would also like to see that medication without cost sharing or any other barriers that may be limit access to care. And then we're working on the smoke-free air. So we want to work with local communities or organizations and have them increase the percentage of people that are covered by smoke-free laws. And we will also like to protect people from the dangers of secondhand smoke. The last area that we are working in is preemption. That will allow us to protect the local government authority to be able to establish stronger laws than what they may have in their state related to tobacco control, and make sure that we're using proven methods, fact-based, to promote good health and well-being for all. So those are some of the areas that we're working on. And if there are any questions, I'd be happy to answer them in the chat.
Terrific, Andrea. Thank you so much. We're so grateful that you shared this great information with us this morning. And I have a couple of reminders before we let you go. We only have 2 minutes left. So one is that we will have our final poll question pop up. And while you're looking at that poll question, you'll see we would like to know, based on your observations among those you serve, which population groups face the greatest barriers to lung cancer screening. Again, this is one where we'll ask you to scroll down to see all the different options. You may make multiple, it's a single choice on this one. So if you could, let us know which you observe have the greatest barriers. So while you're doing that, let me give you a few reminders in these last couple of minutes. We would love for you to join us for our next virtual forum. In 2023, we will also have a virtual series, and they will be around health equity across the cancer care continuum. The first one will be January 26th. It's also a Thursday morning from 9 to 11 a.m., and we would really enjoy having you with us. So another reminder that we have is that we have the Great American Smokeout coming up. 2 weeks from today, November 17th, marks the 32nd annual Great American Smokeout, where we ask people to observe smoke-free that day. And we hope that that will inspire them to make a plan to be quit for the rest of their lives. So 32nd annual Great American Smokeout, November 17th. We ask for your help in promoting and observing that particular event. So one more thing that we have to let you know is that post-event, you will receive a survey. That survey needs to be completed for you to be receiving your CE credits. So if you will take a few moments in the next 24 hours, that email will come to your inbox, fill out that survey, and within the first 2 weeks, you will receive your CE credits based on that. You can also see the SurveyMonkey link in the chat if you want to get a jump on that. Thank you so much for being with us today. It has been our pleasure to have this great panel of speakers and you, our attendees. We're appreciative that you took the time and invested in this education and this information. And we want to thank you for your commitment to fight for a world without cancer. Have a great day.